Good evening, everybody. Thank you very much for taking the time to join us this evening. We're excited to have a very prestigious guest with us this evening, Dr. Wei Chen. And as many of you have known, we've seen tremendous strides forward in the world of lymphedema care and lymphedema treatment, and especially lymphedema surgery in the last 10 years. There are a handful of physicians that we can look at and say they are pushing the envelope as far as lymphatic innovation and surgical procedures. And this evening, I think we can all agree that Dr. Wei Chen is one of those individuals. I've had the opportunity to hear him on a number of different occasions, and I'm always inspired with his outlook on the future of lymphedema and lymphatic treatment and surgery. Dr. Wei Chen is a professor of plastic surgery at the Cleveland Clinic. He serves as the head of microsurgery and supermicrosurgery and is the co-director of the Cleveland Clinic's multidisciplinary lymphedema center. He pioneered procedures that have been adopted worldwide as part of the mainstays of lymphatic reconstruction. Dr. Chen was recognized as one of the most influential American reconstructive plastic surgeons, and in 2020 received the Marquis Lifetime Achievement Award. And with that, I'd like to welcome Dr. Wei Chen.
Thank you, Eric. I appreciate the opportunity, and I'm very happy to spend the evening with my fellow therapists, surgeons, and lymphedema professionals. And I know we have some patients in the audience as well. And I'm going to keep my talk less than half an hour and to leave plenty of time for questions. Okay, now let me bring up my talk. Can everyone see my screen?
Yes, we can.
Okay. All right. Okay, so my talk will be broken down into 3 parts. We may not get to the 3rd part, but we'll cover as much as we can. And then during the Q&A session, we certainly can talk about anything we want, any question you have about any part of the talk or anything about lymphedema treatment in general. So the first part, we will talk about what is lymphedema. We'll talk about pathogenesis, or how this condition developed. We'll talk about primary as well as secondary lymphedema. I'll spend some time on primary lymphedema because that's the area where we're making some significant progress, and we have made some amazing discoveries that are completely opposite of what we thought about the condition previously. And then I'll talk about the surgery. I'm going to try to cover this area fairly quickly because many of you have heard my overview talk about various surgical procedures that are available for lymphedema treatment. I'm happy to go into any specific procedure in greater depth, but I'm going to try to fly through the surgical section quickly. And then the 3rd part is what's the future of lymphedema surgery? And that's the part that gets controversial. And if we have time, and that's also the part that I may not get to, but we'll see. All right, well, let me just get this bar out of my way. I can't see my own, sorry. Okay, there we go. All right, so what I have listed there from step 1 to 9 is the steps of lymphedema pathogenesis. So starting from step 1, you have disruption of flow or insufficiency. If we're talking about primary lymphedema, there's insufficient amount of lymphatic tissue that are present, resulting in inefficient flow. You can think of it as you pinching a garden hose. And what's going to happen is the pressure inside the hose will go up, and that will manifest as lymphatic hypertension. This lymphatic hypertension itself will damage the lymphatic vessel. It will push through the valve, damage the lymphatic valves, making the valves incompetent. It will also damage the lymph vessels, causing degeneration of the lymph vessels, causing the smooth muscle to get damaged, resulting in the lymph vessels to lose the peristaltic function. And then, of course, our body will try to repair itself. And if this repair process fails, then the injury becomes progressive. it's a vicious cycle that's been built up, and it will just continue to worsen. And so interestingly, from step 1 to 4, patient would have no swelling. And this is also what ISL, International Society of Lymphology, classify as stage 0. And in step 5, this is when we start to see swelling. So contrary to popular, what most people think, when the swelling starts, even when there is mild swelling, the disease has been brewing for a while already. It's not a mild disease. It's already been going on for a while. And this is what ISO calls a stage 1. Stage 1 is, and I put it right here, late, meaning it's been going on for a while already. And now the swelling worsens in both frequency and severity. And the damage to the lymphatic tissue continue until we start to get adiposal deposit or lipodystrophy or lymphedema fat, whatever you want to call it. Now lymphedema is no longer a fluid disease. There's also a solid disease component. And as we all know, lymphedema is an inflammatory condition. So over time, inflammatory changes develop in soft tissue as well as skin. So the inflammatory changes in the soft tissue would be the fibrotic scars in the adipose tissue, and eventually this inflammatory process work itself from under the skin to the cutaneous level or the skin level, manifested as elephantiasis. And from steps 7 through 9, it's ISL stage 2 and 3. So there are lots of staging systems out there. It really doesn't matter what staging system you prefer as a lymphedema professional to use. They all describe the same disease process. So it really doesn't matter too much the specific staging system. What matters is this disease process being clearly recognized and understood. And it is important to note that lipodystrophy, or the lymphedema fat deposit, is not all or none. We also frequently hear people saying lymphedema lipodystrophy is a late finding. No, it's not. It's there actually in fairly early part of the disease process. It's just that in the early part, there's so little fat around, it's hard to appreciate. It's too subtle to appreciate clinically. But if you really pay close attention to it, you will see it. And you can also see it on the MRI if you want to quantify it scientifically. All right, so now we will talk about primary lymphedema. What I just mentioned, the pathogenesis, the steps, is common for both primary and secondary lymphedema. For primary lymphedema, we're told by our textbooks, medical textbooks, that it is very rare. But when I look at my practice, primary lymphedema patients represent 40% of my practice, with the remaining being secondary. So secondary is a bit more common. However, primary, 40%, I wouldn't call it rare. It's certainly not rare. I see them in every single one of my clinic. And when it comes to primary lymphedema, these are the names and terms being thrown around. Lymphedema congenita, which is defined as patients developing swelling at birth. And it's also known as the Milroy's disease. And of course, that was discovered and named by Dr. William Milroy, and who practiced medicine in a different century. And there was lymphedema precox, and that's defined as patient becoming symptomatic before age 35, of course, named after Dr. Henry Mage, again, a physician from a different century. And lastly, we have the late onset lymphedema, or lymphedema tarda, and this is after age 35. This hasn't been named yet, and it might be a matter of time before someone put their name on it. And when you look at this, you have to ask yourself, first of all, what do they mean? What do they mean? Are they distinct disease pathologic entities, lymphedema congenita, precox, and tarda? Are they different disease entities? And what's so special about age 35? Why do you call it one thing before 35 and something else after age 35? Is one worse than the other? Actually, yes. The age of onset does mean something, which I will talk about in a little bit. And also, are they predictive of the disease course? Is this classification prognostic? What's the meaning behind it? And do you treat them differently? So if we don't know the answer to any of these questions, why do we even call them by different names? So this is something that as lymphedema professionals, we need to ask ourselves. So now we're going to share with you some of the discoveries that we've made about primary lymphedema. First of all, it's not just hereditary. It can be sporadic. And again, in my practice, I observe probably more sporadic cases of primary lymphedema than hereditary lymphedema. Sorry, I should define what sporadic means. Sporadic means that the patient is patient number one in the patient's family. No one else in the family, or as far as the patient can tell, has lymphedema. So this is a sporadic case of primary lymphedema instead of hereditary. Of course, they can always do genetic study and all that, but we certainly see sporadic lymphedema, primary lymphedema very often. The second key point, and this is very important because it does affect treatment, is primary lymphedema is not a localized disease. What does that mean? That means that when a patient comes in to see me because of a swollen leg, which I see a lot, patient gets referred to me with a diagnosis of primary lymphedema of the leg. There's no such a thing because primary lymphedema is a global hypoplasia or underdevelopment of the patient's lymphatic system. That means if we look at the lymphatic system of the patient's arm, you will find abnormality. If you look at the lymphatic system of the abdomen, you're likely to find abnormalities. If you look at the lymphatic system of the intestine of the same patient, you're likely to find abnormality. It is a global hypoplasia of the lymphatic system. And why is it so much more common in the leg? It's actually not surprising why we tend to see it in the leg, because the legs, in comparison to the rest of the body, is the most dependent part of our body. It's constantly being on the ground. And we all know for management of lymphedema, it's important to elevate and to compress. So elevation is important as part of the management of lymphedema. And like being out of necessity, being on the ground all the time, it's not surprising. We tend to see primary lymphedema becoming symptomatic in the legs more so than in the arms. This also means that disease severity, the severity of primary lymphedema, depends on the severity of underdevelopment or hypoplasia, which correlates really well with the age of onset, meaning that in a patient with severe underdevelopment of the lymphatic system, that patient would tend to develop symptoms earlier in life compared to someone who is only mildly deficient. This patient is likely to develop symptoms later in life. So the age of onset implies severity frequently. There are cases of exception, but frequently time of onset implies disease severity. And this means that a newborn with swollen arms and legs, that is a difficult case to treat because the severity of underdevelopment is likely quite bad. This also means that even if the patient comes in complaining of only swelling in her foot, you need to observe other parts of the body for development of symptoms. You need to observe or recommend the patient observing her arms, her hands, her torso. They may become symptomatic later on in life. And also, this has implication in treatment of cancer or treatment of anything else that requires surgery, because wherever you cut, you're likely to injure some lymphatic tissue. And lymphatic injury that would be well tolerated by people without primary lymphatic insufficiency may not be tolerated by these patients. So this is why sentinel lymph node dissection would be well tolerated by otherwise healthy patient, but may cause lymphedema in patients who are already predisposed. This also means that as lymphedema surgeon, when we're treating these patients, we should be careful and try to not perform transfer procedure, or the transfer procedure should be considered as last resort, because they're much more likely to develop problem when we take tissue from them from another part of the body, such as in lymph node transfer or lymph vessel transfer procedures that involve borrowing lymphatic tissue, healthy functioning lymphatic tissue from another part of the body and using it to treat the affected part. But given what I just said, that there's really no healthy part, there's just varying degree of insufficiency in the body. So here's an example. So these are ICG images, and from 3 different patients. All 3 patients have left leg lymphedema, while the patient in the middle also has right leg lymphedema. But take a look, just focus on the left leg. Compare this left leg to this left leg. So this drawing just basically showing you what we are seeing. So compare patient A, B, and C. So who has the most severe? They all have primary lymphedema. Who has the most severe disease? Well, even if you're not experienced in reading ICG lymphography, you can tell that this patient, the patient in the middle, we see almost nothing. In this patient, there's a lot of, this is what we call Stardust pattern. It is a disease pattern. So the presence of disease pattern confirms the diagnosis of lymphedema. But you can see disease pattern throughout the entire leg and thigh, whereas in the patient in the middle, you only see a little bit in the lower leg and then nothing in the remainder of the leg and thigh. And this patient, you have disease pattern in the leg and nothing in the thigh. The one in the middle has the most severe primary lymphedema because there's such significant degree of underdevelopment. So as I just said, the patient on the left with Stardust pattern throughout the entire lower extremity actually has the mildest disease because there's lymphatic tissue present throughout the entire leg and thigh, whereas the patient in the middle has fairly severe underdevelopment. So in terms of treating the patient, this patient would be much more challenging to treat, and the disease course, the natural history of the disease is likely that the patient will deteriorate rapidly. So we need to intervene quickly and more aggressively. Whereas this patient will most likely behave fairly similarly to those with acquired lymphedema, which in general is much more responsive to treatment, less challenging to treat. So I'm going to bring up another topic which is quite relevant to the discussion of primary lymphedema, and that's the discussion of senile lymphedema. I didn't come up with the name that was the name given by to the entity by the researcher. It basically just talks about, it just means aging lymphatics. So lymphatic function, like all bodily function, decline with age. As we get older, we lose muscle mass, we lose bone density, we don't sleep as well, and our hormones also, we have decreasing for guys, decreasing testosterone, so on and so forth. Same thing with lymphatic function. We lose lymphatic function with time. So this was a very interesting study performed at Hamamatsu University back in 2011. They placed blood pressure cuff that was transparent to ICG signal, and they inflated the cuff to 70 millimeter mercury, which is in general higher than the common lymphatic pump pressure. And of course, at 70 millimeter mercury, we're not going to see lymphatic transport. And then they inject ICG into the foot, and then they start to drop the pressure in the blood pressure cuff by deflating the cuff by 5 millimeter mercury every 2 minutes until they observe ICG movement passing through the blood pressure cuff. As you can see here, gradually, now you're seeing some signal under the blood pressure cuff, and then now it's past the blood pressure cuff. That means at that given pressure, the lymphatic pump function, the lymphatic system generated sufficient pressure to overcome the pressure exerted by the blood pressure cuff. This allows us to know how much pressure the patient is capable of generating. And this is their finding. It was very interesting. Note that the study was performed in healthy volunteers aged 20 to 91, 199 males and 200 females. And look at this graph right here, age 20 to 29, 30, 39, 40s, and male and female. The dark bar was male, white bar was female. And you can see the decline in lymphatic pump function starting in age 30. And then it just gets worse and worse and worse. And when you compare male and female, you also see that female tend to drop their lymphatic function faster. And when we plot this into a curve, we can see that very clearly. So in female, they just continue to drop starting in age 30, and then all the way down to age 90, which is the range of the healthy volunteers. Whereas in male volunteers, we see this plateauing between age 40 to 80. So this is a previously unknown finding. We didn't know, actually, even though it makes a lot of sense, but we didn't know that lymphatic function declines with age. And so with this finding, it now seemed to make sense why we tend to see lymphedema in female. And also, this prompts the question, are some of the lymphedema tarda, so patients who develop lymphedema at age 40 or 50, they were classified or diagnosed with primary lymphedema tarda, actually were senile lymphedema. Or it could be a mixture of both. Maybe they had a primary lymphatic insufficiency, and then as they age, they lose even further lymphatic function, and then they became symptomatic. And another very important implication is that following a surgery, a breast cancer surgery, or a gynecologic cancer treatment, cervical cancer, uterine cancer, ovarian cancer, are patients at risk for lymphedema for life? So that was exactly what we looked into. And we had previously reported this case of 64-year-old female with cervical cancer. She had hysterectomy, oophorectomy, pelvic lymph node dissection, and radiation 30 years ago. And she developed lymphedema 30 years later. So at the time, we were scratching our head, why would acquired lymphedema develop 30 years later? She was, of course, given a diagnosis of acquired lymphedema, but now we know it wasn't just acquired lymphedema. It was acquired lymphatic injury, but with disease onset brought on by this gradual decline, age-dependent decline in lymphatic function. So in summary, primary lymphedema is a global lymphatic hypoplasia, and the time of onset is dependent on the severity of this lymphatic hypoplasia. And both primary and secondary lymphatic injury or insufficiency can be asymptomatic and then triggered by cancer treatment, cosmetic surgery. You probably heard of someone developing lymphedema as a result of liposuction, as a result of minor surgery that really shouldn't cause problem, infection, or otherwise fairly benign lymphatic stress. And so this means that based on this finding, we recommend baseline screening of all cancer patients. Take a look at their lymphatic system before, now this is for the surgeons, take a look at their lymphatic system before you start to cut into the lymphatic system. And you may be surprised what you find. And this also means that if the patient presents with primary lymphedema of a part of the body, the rest of the body should be checked. If your diagnosis is primary lymphedema and you found that the rest of the body were normal, then your diagnosis may be wrong. This is not primary lymphedema. And we're 20 minutes in, and I only have 10 more minutes. So allow me to skip secondary lymphedema and also allow me to get quickly to surgery, and then we'll stop at half an hour. So this is important. So I do want to talk about this a little bit. And lymphedema is not a clinical diagnosis. I think many of you have heard me saying this over and over, because I see the sequelae or the aftermath of people making diagnosis clinically. And I think any medical professionals will agree, you don't treat until you know what you are treating. You should diagnose and cinch the diagnosis, confirm the diagnosis first, and then you start treating. So what does that mean, making diagnosis clinically? Making diagnosis clinically means these are the two things that you're looking at: stemmer sign and the tape measure. Stemmer sign is a positive stemmer sign is inability to pinch the patient's skin because of swelling. Well, just conceptually, you can imagine how flawed this approach would be. And using a tape measure to diagnose, so it's defined as greater than 2 centimeter circumferential difference, or when you calculate the volume using a truncated cone formula, more than 200 cc volume differential is considered diagnostic of lymphedema. And you can imagine how error prone this approach would be. Using a tape measure, it's very hard to measure accurately. And these are all the other conditions that mimic lymphedema. Actually, not all. This is a partial list of conditions that would cause swelling in parts of the body. The list goes on and on. So since this is such an important diagnosis, we need to know for sure. There can't be ambiguity. We need to be unequivocal. And for surgeons, especially if we're going to be cutting into the patient, we need to be absolutely certain. So in my mind, there's no question that image-based diagnosis is a must. So I won't go into ICG lymphography because of time, but it's unequivocal. When you see dermal backflow patterns such as this, you have your diagnosis. But much more than that, we know about the severity. We know what the lymphatic system looks like. We know the anatomy, we know the prognosis, and we know it just gives you so much more information. And furthermore, it allows you to differentiate between primary disease. There are some classic lymphographic findings associated with primary disease versus the secondary disease. So that's another advantage of performing ICG lymphography. And here is still another advantage that I'm going to share with you, since we have lots of therapists in the audience. So I want you to pay attention to this part. So this is a mapping lymphography in a patient with lower abdominal and genitalia lymphedema. So you can see all the injection point, all these green dots in the lower abdomen. The belly button is outside the picture, it's up here. And we know that in the lower abdomen, the drainage pattern should be draining, everything in the lower abdomen should drain towards the inguinal lymph nodes, or the lymph nodes in the groin. But look at, so given that this particular injection should drain towards the left groin, but look at what it's doing. It's draining towards contralateral groin instead of draining into ipsilateral groin. And because of disease, these are compensatory pathways. And this would be relevant for the therapist when you're doing your MLD. You know where to push the fluid. Here's another example of a patient with primary lymphedema affecting her lower abdomen, her genitalia. And this patient, out of desperation, underwent tummy tuck to treat her abdominal lymphedema. And if you look at these injections, instead of draining towards the groin, she drained towards her armpits, axilla. Why is that? Well, because if you look at this, the skin in her lower abdomen used to be in her upper abdomen. And in the upper abdomen, they normally drain towards the armpit. And therefore, these upper abdominal skin were now brought down to the lower abdomen as a result of tummy tuck. So now they drain towards the armpit. And with ICG, we know. All right. So I'm actually at half an hour. So my apology that I won't get to talk about surgery. Actually, let me spend 5 minutes to talk about lymphedema surgery. So otherwise, I'm not doing my job here. So lymphedema surgery. So these are all the procedures that are currently available, going from the therapeutic LVA used to treat established lymphedema. And then based on the experience of therapeutic LVA, we developed a preventive LVA procedure. And then we have the lymph vessel transfer procedure for more advanced lymphedema, lymph node transfer, which I currently no longer perform, but many other surgeons do very much like this procedure. Liposuction, a lot of people call it SAPL, but it's basically lymphedema liposuction and the radical excision. So this is my protocol. If we have time later on, I will go through it. But for now, I will just quickly show you the pictures of these procedures. So LVA involves making multiple small cuts, and then we get under the microscope, we connect the lymph vessel to the vein. I'll just show a little bit of the video here. Now you're looking at a 0.9 millimeter vein and a 0.3 millimeter lymph vessel down there. Just for reference, when heart surgeon performed coronary artery bypass, the average coronary vessels were in 2 to 3 millimeters. So they are about 10 times larger than the lymph vessels that we're working on here. So we're magnified about 30 to 40 times under the microscope. And the suture that we're using is about 8 times finer than human hair. So it's almost invisible to naked eyes. So stitch by stitch, we connect them together, and all right, in the interest of time, we will move on. This is another demonstration of the so-called octopus technique that we developed. This is used in difficult situation when, such as in this situation, we have one vein and we have 3 lymph vessels. And I will play a little bit of this video for the surgeons in the audience who are interested in this technique. So without the octopus technique, we won't be able to achieve all 3 connections. But with octopus technique, we can bunch all 3 lymph channels together and then traction them into the vein. So this is a suture going from outside of the vein through the lumen of the vein, and we brought it out. And then now we will catch all the vein, all the lymph vessels, and then we will traction them into the vein. So the green color that you're seeing, those are lymphozurin that we use to stain the lymph vessel to help us visualize and find the lymph channels. So now we're going to pull all the lymph vessels into the vein. Again, these are all microscopic structures. We're working under the microscope at this time. Now you can see all 3 lymph vessels being tractioned into the vein, and you can see some of the green lymph oozing out. And now they're starting to flow into the vein. You're starting to see the vein being stained green. Okay, so we're going to move on. So this is why LVA is, in general, a highly desirable procedure, because it's so minimally invasive. Bunch of small cuts, and we can potentially take care of this very difficult problem. And patient will wake up with no pain, and it's outpatient procedure. There are various ways to connect them together. I won't go into them now. These are all various anastomotic configurations. And this is what a strong LVA looks like. You can see the lymph flow in this video. This is a double LVA, 2 lymph vessels going into 1 vein. You can actually see the phasic flow of the lymph. You can see a little bit of the retrograde flow even. That's from the pumping of the lymph vessels. Here's another wave that's going to come in right now. All right. So we're 32 minutes. Lympha is essentially the same, but just less. Instead of doing 4 to 5 cuts, we make 1 or 2 cut. Surgery is done in an hour, and it's outpatient. This can be done under local anesthesia. And we have been successful in preventing lymphedema with this procedure. Lymph vessel transplant is used to treat advanced lymphatic injury. And this is lymph node transfer, and that's why I don't like lymph node transfer anymore. I prefer lymph vessel transfer because it's not as ugly. But lymph node transfer, when I was doing it, certainly worked great. But in my opinion, lymph vessel transfer is a superior technique. And these are the places where I harvest the lymph vessels, preserving all the lymph nodes. We only take tissue superficial to all the lymph nodes. And that's what they look like. Scars are unfortunately not avoidable, but they work very well. So prior to surgery, only 2 weeks out, you can see already significant reduction. So I know multiple patients ask about this technique, our flying squirrel lymphedema liposuction. So I will quickly show you some pictures. So this is how much skin, loose skin, that patient would develop following liposuction. So while the current predominant practice is to leave the skin behind, I prefer to remove the skin excess using body contouring techniques. So in this picture shown, this patient just had liposuction completed, and she had positive flying squirrel sign. So what's marked here is how much skin we would be removing. And this is what she looked like on the table right after the skin being removed. There is a long scar as a result of that, but this is the result that we can get before and after. Only 3 weeks out from the surgery, you can see the surgical tapes were still there. Even the patient like this, we can bring about substantial improvement. Note that the quality of her skin also improved because of decrease in inflammation. Someone like this, we can improve to normalizing the leg. Someone like this, we can turn a bulky arm into a skinny arm. So the reason we remove the skin is not to make the patient looking better. In our study, if you're interested, please look it up. It's open access, it's online. We found that by removing skin, we dramatically reduce the complication, the risk of complication. A patient like this to a patient like this. And you can see the scar right here. In the upper arm, the scar is down here, and we couldn't see it. Okay, so we'll skip the hybrid reconstruction. And I will stop here so I can have time to interact with you and answer your questions.
So first off, Dr. Chen, thank you. That's fascinating. And actually seeing the lymphatics, I don't think you can ever get past where we were just a few years ago and not being able to visualize those things. So we do have a couple of questions. I'll just read them off for you as they come in. And for everybody who's attending, feel free to go ahead and put questions into the Q&A box and we'll go through these. So Mr. Kelly Bell is asking, what is the best imaging to identify truncal lymphatic dysfunction?
So truncal lymphatic dysfunction, we need to be more specific. Are we talking about superficial lymphatics, or are we talking about visceral central lymphatics? That's inside, well, actually, I was going to bring up the image to illustrate better, but as far, if we're talking about if the patient has abdominal swelling, then ICG lymphography is still great. ICG, the limitation of ICG lymphography is limited penetration. It's in general about 2 centimeters or so. So it won't allow us to image the central lymphatics. The central lymphatics, to date, probably, there's several promising modality, but in my opinion, and there's some discussion about this, The most promising would be the ones using intranodal injection. So injecting contrast directly into the groin and lymph node in the groin. And then these contrasts would then get into the intrapelvic lymphatics, get into the lymphatic trunk. I'm assuming that's what you're asking. But if you're asking about imaging the superficial lymphatics in the abdominal wall, ICG is great.
Okay, and he had a clarification question, so I do think you addressed. He said, how can you use ICG imaging on the trunk, and what are its limitations? So it sounds like you did address that.
Yeah, let me supplement my response also. Even if there is a central problem is in the central lymphatics resulting in reflux into the superficial lymphatics, it's still worthwhile to image the superficial lymphatics because that's where the intervention takes place anyway. As of today, unfortunately, we don't have reconstructive procedures developed for central lymphatic problems. We're not there yet. Give us more time, we will get there.
We've made huge strides, so I believe it. Colleen asked, what specifically are you recommending for screening lymphedema for cancer patients?
So ideally, let's say a patient is diagnosed with breast cancer, and the breast surgeon is planning on doing sentinel lymph node dissection, or definitely if they're already planning on doing full axillary lymph node dissection, I would recommend performing an ICG lymphography of the arm to see whether the patient is starting out with healthy lymphatics. There may already be primary insufficiency in place. Although, note that I said ideally because that is usually a trying time for the patient. They're dealing with the cancer diagnosis. They're handling the information being delivered to them about cancer treatment, about breast reconstruction. And if we're going to be talking to the patient about lymphedema risk, it could be quite overwhelming. So, but that obviously is a different discussion. What is clear, what's an ideal practice is clear, that we should ideally know what's the baseline condition of the lymphatic system.
We have an anonymous question here for, do you utilize pneumatic compression in your treatment for lymphedema?
Yes, I do. So I know there's some controversy about, not all lymphedema professionals agree that pneumatic compression pump is a good thing. Some feel that it may cause injury, but based on our understanding of lymphatic physiology and pathophysiology, there's really no reason for us to speculate that it would cause injury. It's hard to imagine that it would cause injury. And based on our understanding, it should help. But of course, we don't want to leave it this way. We want our practice to be evidence-based. We are actively designing, conducting study to make it evidence-based. And again, give us a little bit more time. And that for this is a low-hanging fruit. I fully expect, and it won't take a lot of time for us to get back to you with a definitive answer. Not only whether pneumatic compression pump is helpful, which I speculate most likely it would be, but also what would be the optimal pressure to compress? What would be the most optimal compression sequence or program? There are all these different programs, exactly because we don't know what is the best, what is the most effective. So yeah, give us more time. We'll get back to you on that.
That's great. Thank you. Since secondary lymphedema is most common, what are some of the key things that you skipped over in your discussion that we should be aware of?
So secondary lymphedema is not the most common. As I said, the primary lymphedema is significantly more common than what most people think. And I would not be surprised. A lot of the patients diagnosed with secondary lymphedema actually did not have secondary lymphedema. They had primary lymphatic insufficiency, and then they were bitten by a bug, and then they were diagnosed with secondary lymphedema. Those were primary lymphedema. So I can give another lecture on secondary lymphedema, but in general, secondary lymphedema is much less challenging to treat. They're just, they respond so much better, particularly those, if you catch them early, they respond to treatment so much more than primary lymphedema. So in general, upper extremity is more favorable than lower extremity. Secondary lymphedema is more favorable than primary. So if you get a patient who has arm acquired lymphedema and you're catching it early, that's a very gratifying case to treat, because you know that patient will respond well and the prognosis is excellent.
That's amazing. That's amazing. Can you please specify what substance you use to color the lymph? Is it not ICG? And I'm assuming she's talking about during the surgical procedure here.
It's isosulfan blue, even though it became green, but it's blue. Or lymphozurin.
We have a couple of comments here. Thank you, doctor. This is amazing, amazing presentation. Somebody's asking if we could see the protocol for lymphedema, which I think you went over with us already.
Sure. Actually, you know what? It would be helpful that I show that. It is an important, let me see if I can bring that up again. So I didn't talk about it. I just showed it and right here. Okay, so my initial protocol for all patients coming in for evaluation, of course, we do our standard history and physical exam. We do our bioimpedance measurement, lymphedema Q, quality of life assessment, 3D scanning, volume measurement, and then the key is ICG lymphography. I don't routinely get lymphoscintigraphy anymore because ICG lymphography most frequently provides all the information I need. And so with that, I confirm the diagnosis, I stratify disease severity, then I determine whether the condition is solid or fluid predominant. And with experience that if you look at the patient, you feel the affected parts of the body, you can tell already, but if you want to be scientific, look at your quantitative bioimpedance number, how much fluid is in the lymph. You can also perform an MRI that will show you fluid versus solid tissue. And once you have determined fluid versus solid predominance, that was separate the patient into two different protocols. For patient with solid predominance, the goal is to, first of all, get rid of lipodystrophy. And the way you get rid of lipodystrophy is, of course, using liposuction whenever possible. And however, liposuction won't work if the patient has severe fibrosis. Your cannula would go back and forth and you would retrieve nothing. That's when you know you need to perform radical surgical excision. Fortunately, most of the patients are treatable with liposuction. And then we perform our flying squirrel technique. If the patient has a negative flying squirrel sign, we leave the skin behind. We don't remove the skin. So following both liposuction and Charles procedure, we can then go back and perform reconstruction. And this is the hybrid treatment that I didn't get to talk about. But if the patient still have fluid predominant disease, then we're catching the patient relatively early. And we try to offer the patient LVA whenever possible. If the patient has too severe a disease that we don't anticipate LVA to work well, we will also discuss about lymph vessel transfer. Now, note that LVA almost, at least in my experience, almost never completely stop working. It just starts to work less with more severe disease. So even in advanced disease, fluid predominant, we still discuss with the patient about the possibility of LVA, but we also offer lymph vessel transfer in this situation. And so that's basically our protocol. And yeah.
Great, thank you for that. I actually see a question here from a friend, Betty Westbrook. She runs Camp Watch Me, which is a pediatric camp for patients with pediatric patients with lymphedema. And she's asking a question. Can you address pediatric lymphedema patients as candidates the risk and reward for early intervention?
That's a big topic. But it's certainly relevant given what I just discussed. As I said, the age of onset correlates with severity. So the younger the patient, the more severe the lymphatic hypoplasia tend to be. Of course, there are exceptions. That really presents with us with a dilemma because younger patient, there's also concern about the effects of general anesthesia on their development. That's not an absolute contraindication. We certainly do surgery on newborn, really young infants for cleft lip and palate. So if the benefit is felt to be justifiable, then we proceed with treatment. In general, the younger the patient, not just pediatric patient, the younger the patient, the more aggressive we should be, because they're much more likely to worsen because they have more time to worsen. And so I think in general, the younger the patient, the more the benefit of surgical intervention. Compared to lymphedema therapy, obviously surgery is more aggressive, but surgery does yield more fundamental improvement, allowing us to fundamentally impact the disease course. It definitely comes with a set of risks, and it's never a simple answer. Yes, we should operate, or no, we don't operate. It's always a risk-benefit analysis and balance. Right. And it may be different from person to person, from one family to another family, but overall, the younger the patient, the more aggressive we should be, and the higher the expectation or the goals of treatment.
That's great.
In much older patient, we might be happy, or patient might be happy that we're able to stop disease progression, whereas in younger patient, we're looking to achieve more. Although, as I said, there are frequently even more challenging cases in younger patients.
Great, thank you. Thank you for addressing that. So there's a question here from a gentleman who's asking, has this surgery ever been done with somebody who has extreme obesity, or is obesity a concern?
Obesity is definitely a concern. In fact, obesity directly impacts lymphedema pathogenesis and disease course. So for people who are patients with lymphedema who are overweight, my recommendation is for them to lose weight. Frequently, it is difficult for patients to hear about their weight issue because they've been talked to so much, like completely understand, but if the weight is not addressed, their lymphedema won't get better, particularly if we're talking about significantly high BMI, such as BMI in the range of 40s. And lower extremity lymphedema, leg lymphedema in particular, is so adversely affected by weight. So even before talking about surgery, weight is such a significant adverse factor that lymphedema patients should really try hard to lose weight, even without doing anything else, no surgery, no therapy, simply by losing weight. Many patients will see a clinically significant improvement in their condition. Now, in terms of surgery, BMI higher than 35 is a relative surgical contraindication because at this level, the risk of surgery goes up significantly. The risk of complication, we're not even talking about success or failure of the surgery. We're talking about whether the patient can undergo surgery safely is questionable. And the risk just increased proportionally as the BMI increased further beyond 35. So in general, try to lose weight. It would be helpful for the condition of lymphedema, and also to qualify a patient for surgical treatment.
So we have just a couple more minutes here. I'm going to bounce around. We have quite a few questions coming in, but so the question is, there is a pressure difference and circumference difference between the venous system and the lymph system. How effectively is the connection works, and how long?
So That's a great question. The short answer is I have not. I get this question also in surgical conference by other surgeons. Many surgeons performing LVA reported that it would initially work for a few months, and then once the lymphatic system is decompressed, they hypothesize that the flow will reverse once the lymphatic system decompress into the venous system. And once the flow reversed, then the LVA shut down and patient worsened again. Of course, we can only comment based on our experience. I haven't seen that in my practice. So LVA, of course, cannot work. No surgery is 100% successful. However, among my patients who has successfully responded to LVA, I have not seen any one of them worsen. None. Zero. So they improve progressively, usually for at least a year. The improvement is usually almost instantaneous. Sometimes very next morning, patient would say, my arm is so much smaller, it feels so much better, the pain is gone, and it's so much softer. And then I would tell them, you're not seeing half of it yet because the improvement is progressive. We see that patient make progressive improvement for at least a year. Some stabilize at 1 year, some stabilize at 2 years. The farthest we've seen is 3 years out from surgery. They were making continuous progressive improvement. And so no one had worsened after they stabilized.
Fantastic. And last question for you, and I really appreciate your generosity with your time here this evening. Last question is, what is the value of bioimpedance testing in pre and post-operative breast cancer patients when they have SL and B?
So I understand that recently there are lots of talks about using bioimpedance as an early detection tool for lymphedema. I have to respectfully disagree with that. And if any of you are interested in this topic, please look up our study. We had published multiple studies on bioimpedance. Bioimpedance is, in my opinion, tremendously valuable in management of lymphedema, but the value is not in early detection. What does bioimpedance do? It measures how much fluid there is in the limb. Actually, not even the commonly used bioimpedance machine. The quantitative bioimpedance can tell you how much fluid there is in a given limb. Let's say in the lymphedema affected right arm, there's 2000 cc, whereas in left arm, there's only 700 cc. That's the value, allowing you to quantify and allowing you to track longitudinally over time how the patient is doing. Let's say this patient started out with 2000 cc in the lymphedema affected arm. And over time, as you continue to work with the patient, you see this number trending down and approaching normal. That's the value. However, we need to keep in mind that the amount of fluid in our body fluctuate from morning to the afternoon to the evening, and fluctuate after you drink a glass of water, after you take your diuretics, when the weather gets warm. So there are all kinds of things that affect your measurement. Or if the patient just removed the compression garment right before the patient steps on the bioimpedance machine versus another patient who didn't even put on her garment because she knows that it's so difficult to pull on the garment, she's going to come in and take it off anyway. She's just not going to put it on. That will definitely skew your measurement. So when we perform bioimpedance, we need to understand the limitation, first of all, what it does, and then understand the limitation of the technology. It's not, in my opinion, and should not be used for early detection because it doesn't catch early disease. However, in the situation where the clinician doesn't have any other technology to rely on, and they're looking for a additional supporting data to confirm the diagnosis, I don't object to the use of bioimpedance for that. But the clinician should know it's not really designed for that. That's not what the technology is for.
Great. Again, thank you very much for your generous time here this
My
evening.
pleasure.
Really appreciate you being here. For everybody who attended this evening, thank you for being here. Our goal at LymphoPress is to continually push the field of lymphedema forward. Talks like this certainly do that, and we appreciate your time, Dr. Chen. Thank you, everybody. Have a nice
Thank you,
evening.
everyone. Have a good night. Bye-bye.